Good afternoon and thanks for joining us. I'm Judy Simpson. Our focus today is on the #2 cancer killer in the United States. You may be interested to learn that lung cancer is #1 and breast cancer is #3. But the #2 cancer killer is colorectal cancer. As part of our effort to help raise awareness about colorectal cancer, we're going to discuss screening and how it's done. We're also going to discuss the differences between colon and rectal cancer, and we're also going to address treatment. Joining me are two experts from the University of Vermont College of Medicine. Dr. Neil Hyman is a member of the Vermont Cancer Center and a colon and rectal surgeon with Fletcher Allen Healthcare. Also here is Dr. James Vecchio. Dr. Vecchio is director of the Fletcher Allen's Gastroenterology and Hepatology Unit. Thanks so much for being with us. Let's start out talking a little bit about the definition of colorectal cancer.
Well, the definition of colorectal cancer is that there's a cancer in the colon or the rectum. What we do in medicine is divide the colon into different sections. And one of the sections is the rectum, and that's the first 12 or 14 centimeters of the colon. And then the rest is the rest of the colon, which involves the ascending colon, descending colon, and transverse colon. And that's the definition of colorectal cancer.
And so what are some of the basic facts about colorectal cancer?
Well, generally in the United States, in the range of 140,000 people will get colorectal cancer this year. 300 or 400 Vermonters, and about 100 Vermonters will die of the disease this year, and about 56,000 in that ballpark Americans will die of the disease as well. You know, a lot of people think that it's just specific to one gender, but actually it's roughly even in incidence between men and women.
Really? Are a lot of people surprised to hear that?
They are. You know, people have different concepts with respect to which gender is more likely to be diagnosed, but I think it's equally important for both genders.
Are there some symptoms that can act as sort of a tip-off?
I think that's the scary thing for colon cancer. There may be no symptoms whatsoever. Everybody thinks that there might be symptoms, that there'll be bleeding or pain. Some of the symptoms that could occur would be a change in bowel habits or bleeding. But sometimes there's no symptoms at all, and the first symptom will be the discovery of colon cancer. And that's why we emphasize prevention or screening to try to look for colon cancer before it has symptoms.
And I might add, you know, on that, and that's one of the relatively unique things about colorectal cancer is that often we talk about early detection because early detection is critical for good outcomes. But with colorectal cancer, we can actually do better. And what I mean by that is that not all, but the majority of colorectal cancers start as these benign polyps. So what we're really two goals of screening. One is to find these polyps and remove them before they get a chance to become cancer some number of years later. So the screening actually prevents cancers, and then of course we know that patients whose cancer is detected before the symptoms Dr. Vecchio described do much better than those that are detected once they develop these symptoms.
And so Neil's mentioned this word polyp, and everybody's, I can imagine, thinking, well, what's a polyp? What could a polyp be? And that's the concerning thing, is that we're not understanding exactly why a polyp occurs. It may be a genetic disorder as well, but a polyp is just a bunch of cells that are precancerous, and if you wait too long, and sometimes it's 5, 6, 7 years, that polyp can turn into a cancer. But if we can catch it early, remove it through colonoscopy, then that natural history could be changed.
Is one of the problems just the area of where this occurs, getting over that issue with a lot of folks?
It is, and you know, nationally, only about the same in maybe 50–60%, something in that range of people do get screened because, for example, we'll talk perhaps a little bit later about colonoscopy. It's not imaginable that that's not a miserable thing to do, but actually it's, for most people, not, you know, it tends to be a painless procedure. But you're absolutely right. You know, I think that we're getting over some of those barriers or obstacles, but it's certainly true.
Do you find that people nowadays are more receptive maybe to taking on that responsibility?
So I think people are understanding it more. It's more in the news. It's the celebrities have taken hold. Katie Couric effect, Ronald Reagan in the past. So I think that the fear of having a colonoscopy should be dissipated. I don't think it should be fearful or embarrassed. I think the whole idea is that this is part of medical screening, medical prevention, and it's very important.
Can this kind of cancer be prevented?
Well, it can, and you know, so that I think we also, in fairness, I don't think that we could say that any screening modality completely prevents the incidence of cancer, but we do know that people, for example, who've had colonoscopy have a marked reduction, maybe as much as 70 or 80 or 90% in their long-term incidence of colorectal cancer. So, you know, colonoscopy definitely diminishes, the extent is a little bit controversial, but diminishes significantly the chance of ever getting the cancer in the first place.
And the way that I would add to that is that some screening is better than none, and colonoscopy is one of the best, but the best one is what the patient gets. If the patient doesn't get any kind of screening or any kind of prevention, that's the worst case scenario. And so what I try to tell my patients is get some type of screening. Colonoscopy is a good one. It may be the best one. The literature is unclear right now, but it's better than nothing.
And so what are some of the key things that we can do as individuals to prevent this cancer?
I think the things that prevent colon cancer are exercise, good diets, calcium and milk have been helpful in preventing colon cancer, and then getting screened. Anybody over 50 should be screened.
I wanted to add, and I think we would both highlight the impact of screening dramatically dwarfs any of the lifestyle things. I think we'd all love to be able to say that a certain diet, but as opposed to, for example, lung cancer and cigarette smoking, where there's a dominant risk factor, all of these things really diminish the incidence around the fringes by very, very small amounts, where it's really screening that is the intervention that really has the dramatic impact in terms of reducing cancer-related incidence and mortality.
All right, well, let's talk about the screening. You mentioned anybody over the age of 50, and usually if you go to your doctor on a regular basis, he'll say, you're turning 50, this is one of the things you need to consider. What actually happens when we talk about screening? What does that mean?
Well, there are several different options, as Dr. Vecchio pointed out. You can have just your stool tested for blood. There is sigmoidoscopy, which perhaps goes roughly a third of the way around the colon, but has the benefit of being an office-based procedure, or colonoscopy that looks at the whole colon. There are some radiologic studies, but frankly, they've never really been shown at this point to be beneficial in terms of reducing cancer. So I think the key ones are having the stool tested for blood, having the sigmoidoscopy or the colonoscopy, and as you go up the line, it's more invasive, if you will, but the protection increases. So it's always a trade-off.
So even if you are just screening for blood, that doesn't necessarily mean that you're out of the woods or that there wouldn't be a problem, because, as you said, sometimes there's bleeding, sometimes there's not.
Correct. And I think the most important thing is to get something done. Don't ignore it. And the feeling is going through colonoscopy could be very difficult. I think the hardest part, or the most difficult part of colonoscopy, is the preparation. And that's what patients complain about the most. But I think it's the most important part of colonoscopy is the preparation. I think if you're not cleansed out properly, don't go to the procedure. I think as a gastroenterologist, the most important thing I want to be able to see. And if there's fecal material there, I can't see the areas that well.
Well, let's face it, if you're going to make the decision to go through this, you might as well go all the way. Now, it is rather, uncomfortable, because you do have to drink a gallon of, I don't know what it is.
It's a split. It's called Go Lightly. It's a split prep. So it's usually 2 liters the night before and 2 liters the day of the procedure, and that's the best way to do the prep. That's well documented now. So it is a gallon, but it's 2 liters first and 2 liters later. And then usually it's about a day or so prior to that you should be on a liquid diet, because the prep is the most vital. If I can get anything across in this program, is make sure that the preparation, you're cleansed out properly.
So it doesn't do you any good to start and then just say, yeah, I just can't do it.
Well, then cancel and then reschedule or discuss it, but you have to do it properly.
Okay, so we get through the prep. We've done that properly. We're headed to the hospital for the procedure. What happens next?
So that what would happen is that most people choose to have sedation with it. And the reason you say, well, how could you not have sedation with something like that?
Yes, knock me out.
But, for example, I'm over 50 and I had mine done without sedation, because it's not really a painful procedure, but it's not intuitive that it's not painful.
Right.
How can this not be good? So to me, is people, even though at the end, if sometimes we do, people, they don't want any sedation and they're fine. But to me is that people who have it without sedation, sometimes they're just saying, I'm waiting for it to be uncomfortable, and it turns out never. Who needs that either?
Right.
So most of the time you'd come in, you'd get an intravenous, we'd give you a combination of sedative, medications, depending on the person, make people as sleepy as they want to be, and most people kind of wake up and say, "Did you really do that already?"
Yeah, no, I was counting, and the next thing I knew, the curtain opened, and they said, "Okay, see you in 10 years."
Right, exactly.
So, and that was sort of the extent of it.
Yeah.
I guess I'm surprised to hear that people wouldn't want to be sedated. I mean, it's one of the procedures that you endure, but you don't want to be there participating, really.
Right. No, I say the exact same thing, is that I say this is not one of life's experiences that needs to be experienced to the fullest. So very seldom are people sorry that they don't remember any part of the procedure.
Okay, so what are you looking for when you're doing this procedure?
We're looking for anything that's out of the ordinary in the colon, and most often we're looking for these growths called polyps. And on the right side of the colon is where they can be very difficult to be seen because they're flat. And so that's why it's very important, again, I'll go back to the prep. If the preparation isn't very cleansed, then these small flat polyps could be missed. And so if you can see them, we'll remove them.
And so you remove them right there, they don't have to come back?
Exactly, no, done at the same time.
Is there any kind of after effects from having polyps removed?
The most common there are, with any procedure, with any invasive procedure, there are always complications, and one of the major complications would be bleeding if you cut the surface and we coagulate the surface at the same time when we do the colonoscopy and the polypectomy, or making a hole in the bowel is quite rare as well.
Right.
But again, these are rare complications, but can occur.
And so someone comes out of sedation and they've been told, well, we took away a couple of polyps or removed several polyps. Is that cause for alarm or concern for the patient?
I think that's a good thing. That's the purpose of the procedure.
Right.
But then the next step would be, when do we do this again? And there's strong literature to tell you what type of polyp it is. If it's a precancerous polyp, then it might be 5 years. If there are multiple precancerous polyps, it might be 3 years. If it's a polyp that has a lot of concern, we might do it in 6 months or a year.
I might highlight that, as Dr. Vecchio points out, we use this concept of an index colonoscopy, meaning your very first colonoscopy at roughly the age 50, that the findings, meaning how many polyps you have, and there's different kinds of polyps, really guides what the most appropriate interval would be. So if you had a colonoscopy and it was completely normal with an adequate preparation, you wouldn't need anything for 10 years, not a stool test, not a sigmoidoscopy. You'd just be done with colorectal cancer screening for 10 years. On the other hand, if you had a couple of polyps, for example, a common recommendation would be 5 years, for example, after that.
And so does heredity play any part in colon cancer, do you know?
It does, and there's two different, branch points, if you will. So we know that people who have a first-degree relative with colorectal cancer, meaning their brother, sister, mother, or even children, are at increased risk. And, we start screening those people usually at age 40, and depending on the number of the age, it might be every 5 or 10 years, starting at age 40. There are some high-risk populations, and a small percentage of people belong to these families where have a very high incidence of colorectal cancer, and we actually call that Lynch syndrome. And that's an important syndrome that we've made a lot of progress in defining the genetic propensities and identifying these families and preventing the present or the future generations from having the same fate that the previous generations have had.
It's a small percentage, but it's a very important percentage. I'd like to make one other point as well, is that for African Americans, they should be screened at 45 years old, not at 50. It's been shown that in good literature now that the screening should occur at 45-year-olds rather than 50s.
And so these initial screenings really will be your baseline for the rest of your life when it comes to your colon health.
Correct.
Yes.
And it might also affect your family.
Let's recap a couple of things that we need to be aware of regarding prevention and detection of colorectal cancer. What about prevention again? Obviously screening.
Some type of screening. Get something done. Colonoscopy is probably considered the best, but it is invasive, but nothing is the worst.
And I might also add, on the other side, is that being that you're trying to prevent the cancer that's going to accrue in 8, 10, 12, 15 years, there is also an age beyond which it's enough. So I think sometimes people want to have colonoscopies, into their 80s and stuff. I think that we also have to be very careful, to decide when the risks or it's just inappropriate. So I think that's another big issue too, is when to stop.
Is it a relatively slow forming cancer?
It is. So we think that for the sequence, and that's why it's so amenable to screening, because we think it might be 8, 10, 12, 15 years from a polyp to becoming a cancer. So it gives us a long window where we can find, and that's why the screening intervals can be so far apart.
But the important part is to get the screening, and don't be afraid of pain. But it'll be a little uncomfortable in the preparation department, but it's so important. That's probably the most important part of the screening.
Absolutely.
Well, I want to thank you both for joining us today and talking about this topic that not a lot of people like to talk about, but it certainly is very important for your personal health.
Well, we do.
That's true. And you were terrific. Thank you so much.
A pleasure. Thank you very much.
That's our program for today. I'm Judy Simpson. We'll see you again next time on Across the Fence.
For a video copy of today's program, call toll-free 1-888-ATF-3430. Across the Fence is brought to you as a public service by University of Vermont Extension and WCAX-TV.